In part 2 of this series, we will discuss on the mode of transmission of coronavirus and the spread of disease. Coronaviral infections are common among bats and rodents. Cross-species infection into the humans occur when the natural barriers are breached. The portal of entry of coronavirus into the humans is through the respiratory tract. Majority remain asymptomatic after coronaviral infection. In a proportion of patients, the viral replication continues and they may become symptomatic. When the infected individual moves into the community without any barrier protection, there is high chance of spread of infection to others. Of infection can occur in closed spaces like households and in workplaces. The risk of transmission is higher among symptomatic individuals when compared to asymptomatic ones. Infected people with minimal or no symptoms contribute to 20 to 40% of total transmission. It has also been found that extremes of ages, that is age less than 5 years and more than 65 years, have high chance of acquiring infection from an index case. Children and adolescents have higher proportion of asymptomatic infection when compared to adults. Household contacts who share bedroom and speak to index case for more than 15 minutes and non-household contacts who use common modes of transport or workplace are prone to infection. The common modes of transmission of infection can be mediated by droplets, airborne, direct contact, or through indirect contact. Close contacts within 2 meter or 6 feet distance are more prone to infections. Droplet-mediated infection is the most common mode of transmission that was observed initially. However, aerosol-mediated transmission is also being recognized increasingly. Vertical transmission is extremely rare in SARS CoV infection. The usual size of droplet vary between 20 to 100 micron and they carry a high viral load. Most of them fall down due to gravity within 2 meter distance and may travel more if the conditions are windy. A vigorous cough can produce particles that travel beyond 2 meters and sneeze can produce droplet particles that travel beyond 6 meters. Aerosol are smaller particles which are usually less than 5 micron in size which stay for more than 2 to 3 hours in the air. They may travel many meters and are increasingly being recognized as a major mode of transmission. Fomite spread may also be an important mode of transmission where inanimate objects get contaminated with viral particles. SARS CoV-2 remains viable in copper for 4 to 8 hours, in cardboard for 24 hours, stainless steel for 48 hours, and in plastic and glasses for 3 to 5 days. SARS CoV-2 virus have also been isolated in stool specimen, blood, ocular secretion, and saliva. However, majority of these secreted are dead viruses and non-respiratory transmission risk is extremely low. Perinatal transmission occurs in about 2 to 10% of cases. Fortunately, the rate of vertical transmission is extremely low. It is safe to room babies with mother and continue breastfeeding irrespective of their COVID status, provided COVID appropriate behavior is maintained. Even if the babies are infected, majority of them remain asymptomatic or have mild illness. Children contribute to 8 to 10% of global burden. They may either be less affected or less tested as majority of them remain asymptomatic. The possible reasons include stronger innate immunity, lack of comorbidity, restricted outdoor activity, variable expression of ACE2 receptors with age, and a regenerative capacity of the alveolar epithelium. When an infected person moves into the community, he may spread the infection to other people. The incubation period varies from 2 to 14 days with a median duration of 5 days. The period of infectivity varies between 2 to 3 days before symptom onset to 5 to 7 days after symptom onset. The virus is detectable in secretions for up to 1 month, however, they are not viable after 10 days of infection. Case reproduction rate or R-naught is the number of people infected by a person. We can see here the usual R-naught for SARS is about 2 to 4 when compared to measles, which has an R-naught of 18. At the beginning of pandemic, the R-naught for SARS CoV-2 was about 2 to 3. R-naught can be of two types. Basic R-naught denotes the maximum potential to infect people with no prior immunity. Effective R-naught is the current vulnerability of the population based on their immunization or prior exposure. R-naught depends upon the infectiousness of a person, immunity of the population, and the preventive strategies and vaccination policies that are currently in place. For an epidemic to be controlled, R-naught has to be less than 1. Like any other viral infection, the usual course following the exposure to virus will be an incubation period after which the person becomes symptomatic and majority of the symptoms resolve within a week. A proportion of these patients may have an unprecedented course with worsening symptoms and further complications. Staying away from mass gathering, wearing masks, maintaining social distancing, good hand hygiene, and staying at home and a good vaccine coverage can help in stopping the spread of COVID. If you like these videos, please subscribe us and follow us for new updates.